Just so folks know, we've had some effectively implied allegations that some of us don't care about access to affordable care. I actually am a doctor who Tuesday and Monday will be in a safety net hospital for the uninsured, or the poorly insured, which includes Medicaid. And so just let's get that on the record. I got lots of questions, so hopefully I can run over. Mr. Cohen, I'm not clear. Will CMS propose something about allowing premiums to go into a health savings account? Will that money, of the premium which goes into the health savings account, will that be considered as regards the MLR? You follow what I'm saying? So medical loss ratio, will that, please?
Yes, it will be considered first dollar coverage for purposes of MLR, to the extent that it's spent.
So if someone does not spend their money in their health savings account, the insurance company does not get credit for an expenditure as regards the MLR?
That's right.
So if somebody is frugal and doesn't go and buy overpriced goods, rather does preventive medicine on their own, takes care of themselves, keeps their weight down, etc., the insurance company will be penalized?
No, they're not penalized.
But it won't count against their MLR, and you're going to come back and take a portion of that, and you're going to come back and make them rebate that cost. Is that correct?
The medical loss ratio provision, or the 80-20 rule, requires that insurance companies spend 80 cents of every premium dollar on actual health care, and if the money isn't spent, it wasn't spent.
The deposit in the HSA does not account as an expenditure. It's only if the patient spends the money.
Right.
So we're trying to hold down costs, but we're basically putting in incentives to spend the money. By the way, it's hard to keep a straight face when Mr. Waxman speaks about access to affordable care. The only thing I've heard about this bill is that premiums have gone up by $2,500 since it was passed. It's kind of curious, isn't it? Dr. Scharfstein, only 65% of doctors in Maryland accept Medicaid patients. I gather that's a statistic that I can give you the source from, Health Affairs. How many of those Medicaid patients unable to find a primary care doctor seek their care in an emergency room? Do we know those statistics? Some states do know that statistic.
I don't know if I have a specific answer to that question.
Then let me go on, because I have limited time. I don't mean to be rude to any of you. I apologize. Now, the issue is, in Maryland Medicaid, I presume there is no deductible.
Absolutely. Correct. Now,
y'all guys make out like a bandit. If I was a big blue state, I'd be all for this expansion because according to Kaiser Family Foundation, you're going to save $500 million over 10 years. Why wouldn't you be for it? But let me put myself in the role of someone that I might be seeing Tuesday morning in a hospital if I were in Maryland instead of Louisiana. You're making 140% of federal poverty level. The state grabs the money, man, we're glad, it helps our budget. But now I'm on the exchange. I have a $2,000 deductible. As Mr. Smith points out, I'm paying $600 a year in a premium. Do we really think that family at 140% of federal poverty can afford that $2,000 deductible?
Well, from my perspective, this has a lot to do with compared to what? Someone at
compared to your current Medicaid plan.
140%, there's no access to Medicaid. So they have no.
Oh, I thought you said in your testimony that you have up to 200% of poverty level in your Medicaid plan.
No, we do not.
Oh, then I misread that.
For an adult. So they have no access. So we're able to give them affordable access through a subsidy.
Now, okay, then let's just take that person at 140%. Do we really think they're going to be able to afford that $2,000 deductible? By the way, if I was an insurance plan, I'd be moving to your state too. Now we have the federal government telling you you have to buy insurance. It isn't competition. It's a forced market. Do we really think that family at 140% of federal poverty can afford that $2,000 deductible?
Well, we certainly think that there's a lot of value for them, and part of what we're going to be doing and what we're working with so many people in Maryland is to figure out how to develop an outreach plan that engages.
Even though it's going to cost them $2,000, I tell you, I like Mr. Smith's line. It's not a percentage; it is the dollar amount. And when you're at 140% of federal poverty, $2,000 might as well be $50,000.
It's not every family that has to pay $2,000. And
only if they access the insurance portion. Let me go to Mr. Allison, Dr. Allison. I'm sorry, Dr. Allison. In your testimony, you mentioned that the state of Arkansas will have to come up with $500 million between January and June 14 to implement this plan. Is that correct?
That's not correct, sir.
That's your testimony.
That's not what the testimony says. The testimony says that the legislature will have to appropriate $500 million for the second half of state fiscal year 2014. That would include In this case, almost all federal funding.
So that's going to be all federal dollars? It won't be state dollars?
Almost all federal funding.
Okay, so they have to appropriate federal dollars?
Correct.
Okay. That's interesting. And the economic aspect of this, by the way, let me just point out, if I may go just a second longer, the Kaiser Family Foundation study that Mr. Waxman had proposed is going to cost Louisiana $1.8 billion over 10 years, Arkansas $1.2 billion, and that's assuming that we don't have to raise taxes on the federal or state taxpayer to pay for this extra money, which is an assumption which just seems a little silly. I'm over time. I yield back. Thank you. First, let's just give some reality to some of the quotes regarding Medicaid expansion and improving health care. That Oregon study you quote, Ms. Mann, was a study limited to Oregon on an outpatient basis, and there is some evidence that people felt better just because they won the lottery. Secondly, as regards the New England Journal of Medicine article you quote, Dr. Sharfstein, it was driven by New York solely, and in fact in Maine, although it was not statistically significant, the Medicaid expansion resulted in poorer outcomes among those who were on the Medicaid. Now, it was not statistically significant, but that was entirely driven by the state of New York. And as regards Mr. Ingalls, speaking of the do-gooder states, I'll point out that New York pays physicians less well than does Louisiana and Texas, and only 60% of physicians in New York accept Medicaid. That is not access. Now, that said, just to clear up the record a little bit, let's go to, oh, heck, dadgummit, I lost my questions. Here we go. Now that we know, Mr. Smith, that the one thing that has been shown to lower costs, which is health savings accounts, will not be allowed in the MLR unless it's actually spent, i.e. we're no longer lowering costs, we're now encouraging insurance companies either not to sell them or perhaps the insurance company to encourage the person to sell it. What data do you have in your state on the effect of the increased premium cost on someone who's, say, 200% of federal poverty level, who's currently employed with employee-sponsored insurance, dumped into the exchange, as McKinsey Quarterly says about 30% of these employers will do, now has an actuarial value of 60%. What do you project is going to happen to that person?
Thank you, Mr. Cassidy. Again, we have been modeling the PPACA premiums in Wisconsin Medicaid since the 1st of July.
So you actually are seeing, this is not a computer model, you are actually got real-life data.
Yes, sir.
Okay.
This is the actual experience. Wisconsin has already expanded Medicaid coverage. We have parents, caretaker, relatives up to 200% of poverty. Some of our eligibility groups of transitional medical assistance, individuals with income above 300% of poverty. We have started applying only the premiums, not any of the additional cost sharing.
Not the $2,000 deductible?
No, sir. This is only premiums, not any additional cost sharing that would be in effect. So in the results to date, people at the lower income level, again, because they're looking at a dollar amount. They're not thinking of a percentage.
Yeah, Washington, we speak about percentages, huh? But we're actually talking about a dollar amount.
Yes, sir. So at 133 to 150% of poverty, and again, because the poverty level includes not only someone's income, but also the size of the family, and so you're a percentage of your gross income. So
please hurry. I have one more question.
I apologize. For people paying over 200% poverty, the average now of $200 a premium, participation was cut in half. So people are saying, we're not paying $200.
So 50% more people are without insurance?
50% of people who had been enrolled dropped their Medicaid coverage when premiums.
So when that working family's employer puts them on the exchange and they have an actuarial value of 80% with the employer, but it may be 60% on the bronze level, they're facing premiums and deductibles they've no longer faced before. They are dropping their coverage potentially?
Exactly, because you have, again, the employers.
This is good for the American worker?
I think the results are going to be quite different.
And this is not theoretical, this is your actual experience, correct?
Yes, sir.
Oh, now, Mr. Greenstein, we speak of percentages in D.C., isn't it interesting? And that Kaiser Family Foundation, based on the Urban League, speaks about how much Louisiana is going to get. But actually, it's going to cost our state, according to that study, $1.8 billion over 10 years, please.
We suspect that those figures actually are understated and don't capture the full administrative costs.
And they also, I might say, probably understate the amount of taxes that will have to be raised for those costs, a macro effect that's not, that it's ignored. Continue.
Member of the subcommittee.
Likely. When we looked at the study, we recognized that there were very large shifts in winners and losers. Some states end up reducing their overall burden, some states increase. But when we talk, and a good part of the discussion today has been about how states are going to save so much money by Medicaid expansion, it's just shifting costs from one place to another. At the same time, this is all net new spending.
I agree with that. So one more question for Ms. Mann or Mr. Cohen.
We'd better cut it off.
Oh, my gosh.
You can submit it in writing. You have till December 27th, sir.
Thank you all.